welcome. This is the first part of our module for today. Our topic now is skin and subcutaneous. As for the outline, we will start
We
discussing
can't see anything, dog.
first before we discuss some pathologic conditions under inflammatory, injurious, infectious, and, and benign and malignant tumors. Anatomy and histology. So the skin is comprised of three distinct tissue layers. The outermost layer is the epidermis, which is a stratified squamous epithelium that is composed.
Uy. Okay, how was that? Were you able to hear the audio?
Yes, Doc. Loud and clear.
Dog.
Okay,
Yes,
okay.
Doc. Doc.
Yes, Doc. Thank you, Doc.
Let's continue with
Composed mainly of regenerating keratinocytes that are moving up through four or five histologically distinct layers. This layer, the epidermal layer, is avascular, so it obtains all its nutrients from the dermal vasculature by diffusion. Deep to the epidermis lies a thick layer of connective tissue, which is called epidermis. It consists of collagen for strength and elastin for flexibility. This layer also contains your nerve endings, blood vessels, and adnexal structures such as your hair shafts, sweat glands, and sebaceous glands. The hypodermis is the third and the deepest layer of the skin. It consists mainly of loose vascular connective tissue that is infiltrated by your fat cells or your adipocytes with the main function of thermoregulation and energy. So the stratum basale or the germinative layer is the deepest epidermal layer with a single layer of continuously replicating cuboidal to columnar epithelial cells. This layer is the beginning of the life cycle of your keratinocyte, and it serves as the regenerative source of epithelium in the event of a partial thickness wound. The keratinocytes that start from this layer evolve and mature as they move upward and outwards to create the remaining layers of your epidermis. Now, in this layer, the keratinocytes are bound to the basal lamina by what you call hemidesmosomes. Point mutations in this layer causes your blistering diseases such as your epidermolysis bullosa and is associated with the spontaneous release of dermal epidermal attachments. The second layer is your stratum spinosum or the spiny layer or prickle cell layer. This is the thickest layer of your epidermis and it contains about 5 to 15 layers of cells connected to each other by, yes, the desmosomes. In the spinous layer, the cells lose the ability to undergo mitosis, but they are largely responsible for protein synthesis, primarily keratin. Now, the keratin forms filament bundles called your tonofibrils that converge on the hemidesmosomes and the desmosomes to give the skin strength to withstand friction and shear force. So this provides the flexible scaffolding of your skin, meaning it gives the skin the ability to resist external stress. The third layer is the stratum granulosum or your granular cell layer. It contains several layers of flattened cells that are undergoing terminal differentiation. In this layer, the cells begin to immortalize and lose their nuclei as they move away from the nutrients located in the deeper tissues. Within these cells are structures called the lamellar granules, containing lipid and glycolipids that eventually undergo exocytosis, filling up the intercellular spaces with lipid-rich material. This layer, the stratum lucidum, is composed of about 3 to 5 layers of flattened eosinophilic cells, creating a clear or translucent layer that provides thickness and strength to withstand friction. This layer is present primarily in the thick, hairless skin of the palms and the soles, also known as glabrous skin. Now, the final layer is your stratum corneum or your cornified layer. It is the outermost layer of your epidermis. These protein-rich flattened keratinocytes are now anucleate without nucleus and are surrounded by lipid-rich material. Together, the cells and the surrounding matrix in this layer serve to protect the tissue from mechanical, chemical, and bacterial disruption while preventing incessible water losses through the skin. In this horny layer, as the keratinocytes age, the once numerous intercellular connections disappear, and then the dead cells are continuously being shed off in a process called desquamation. Okay, so far, can you catch up? Recap, no? The different layers of the epidermis represent layers of keratinocytes at different stages of their approximately 30-day life cycle. The keratinocytes make up about 90% of the cells of the epidermis. Okay? To remember the layers, from the most bottom to the outermost, it's easy. You just see CLGSB and make a mnemonic. And the mnemonic that I have come up with for myself is, come, let's get some beers. Can you make your own mnemonics for this one? Now we move on to discussing other cells in the epidermal layer. So Langerhans cells make up 3% of the cells in the epidermis. These are immune cells that are typically found within your stratum spinosum. These are mobile dendritic cells that interdigitate between your keratinocytes, and they use their characteristic rod or racket-shaped Birbeck granules to sample any antigens that attempt to pass through the skin. These monocyte-derived cells represent a large part of the skin's adaptive immunity. The Langerhans cells are functionally impaired by your UV radiation, specifically UVB, and they may play a role in the development of cutaneous malignancies. The melanocytes are cells that are found scattered throughout the stratum basale. Exposure to UV radiation causes melanin to be manufactured from tyrosine and cysteine, and accumulation of this melanin in the keratinocytes results in the darkening of skin. Now, despite differences in skin tone, the density of your melanocytes is constant among individuals. It is the rate of melanin production, transfer to the keratinocytes, and melanosome degradation that determine the degree of skin pigmentation. Now, what are the factors that increase melanin production? You have increased exposure to UV radiation, your estrogen, adrenocorticotropic hormone, and melanocyte stimulating hormone. Now, when increased melanin accumulation happens, this serves to protect the DNA of your epidermal cells from the damaging effects of the UV rays and the breakdown of folic acid, which is a nutrient that is necessary for our health and well-being. Now, when there is too much melanin, this can interfere with the production of vitamin D, which is also an important nutrient involved in calcium absorption. Thus, the amount of melanin present in our skin is dependent on a balance between the available sunlight and folic acid destruction and the protection from UV radiation and vitamin D production. Merkel cells are slow-adapting mechanoreceptors essential for light touch sensation. They are typically aggregates among the basal keratinocytes in areas where light tactile sense is needed, such as your digits, your lips, and the bases of some hair follicles. The Merkel cells have expanded terminal discs in the basolateral portion of the cell, and these can come in contact with afferent unmyelinated nerve fibers that communicate with the central nervous system. Now, the clinical significance of your Merkel cell is that in the setting of your Merkel cell carcinoma, which is a rare malignancy, The Merkel cells have your uncontrolled growth. Okay, so let's move on to the epidermal appendages like your sweat glands. The first type of sweat gland is your eccrine sweat glands, which make up majority of the sweat glands in the body. They are present in greatest numbers on the palms, soles, axilla, and the forehead. These glands are the most effective means of temperature regulation or thermal regulation via evaporative heat loss, and they respond to emotional as well as to thermal stimuli. Now, eccrine sweat is mostly made up of water and sodium chloride, but they also contain a mixture of many other chemicals originating from the interstitial fluid and the eccrine gland itself. The second type of sweat gland is the apocrine gland. These are found in the axilla, breasts, face, scalp, and the perineum. These are larger and they open into hair follicles instead of onto the skin surface. And although they are present from the birth, the secretory function of apocrine sweat glands does not begin until puberty as they are typically activated by your sex hormones. The apocrine glands produce viscous, lipid-rich sweat, which is also comprised of proteins, sugars, and ammonia. The secretion from your apocrine glands is initially odorless, but bacteria in the region may cause an odor to eventually develop. It is in these glands that suppurative hidradenitis may develop. A third type of sweat gland is the apoecrine sweat gland that presents during puberty. They develop by apocrination of your axillary eccrine glands. Now, the apoecrine glands are more similar to your eccrine glands in that the distal duct connects and empties the sweat directly onto the surface of the skin. But in addition, the apoecrine gland produces copious salt water secretions that are similar to your eccrine glands. Now, this is your pilosebaceous unit, which is a multi-component unit made up of hair follicle, sebaceous gland, and erector pili muscle, as well as sensory organs. These units are responsible for the production of hair and sebum, and are present almost entirely throughout the body except for the palms and the soles and mucosa. They are lined by the germinal epithelium of the epidermis, and thus they serve as an important source of epidermal regeneration after partial thickness injury or split thickness skin grafts. Now we move on to the dermal layer. The dermis is composed of two distinct layers, the papillary and the reticular layer. The papillary layer is the superficial layer of the dermis that projects into the stratum basale of the epidermis to form finger-like dermal papillae. These papillae increase the surface area between the dermis and the epidermis and thereby increase the resistance to shear forces. And this also facilitates greater diffusion of your nutrients across the dermo-epidermal junction. The papillary layer is characterized by a greater density of cells, including your fibroblasts, adipocytes, and phagocytes. It also houses many capillary loops, lymphatic capillaries, nerve fibers, and the Meissner's touch receptors. Underlying the papillary layer is the reticular layer, a thicker layer that is almost entirely made up of a coarse network of fibers and the ground substance that surrounds it. Elastin fibers provide elasticity to the skin, enabling movement. Collagen fibers provide structure and tensile strength, which is the property of the skin that resists stretching. And collagen also binds water to keep the skin hydrated. About 98% of the dry weight of your dermis is made up of collagen, typically 80 to 90% type 1 collagen and only 8 to 12% type 3 collagen. Now types 4 and 7 are also found, but in smaller quantities in the dermo-epidermal junction. The reticular layer is very well vascularized and has a rich sensory and sympathetic nerve supply. The fibrous network of the dermis lies within a hydrated amorphous ground substance made up of a variety of proteoglycans and glycosaminoglycans. Let's enumerate dermal cells. Okay, fibroblasts are the cells that are found in the loose papillary layer, and these are the fundamental cells of your dermis. They are responsible for producing all dermal fibers and the ground substance within which these fibers reside. They are typically spindle-shaped or stellate-shaped and have well-developed rough endoplasmic reticulum, which are actively producing proteins. The fibroblasts can also differentiate into myofibroblasts, which harbor myofilaments of smooth muscle actin and rarely desmin. This helps to decrease the surface area of wounds by contraction. Because of these fundamental functions, the fibroblasts are the workhorses of wound healing, whereas your macrophage are the orchestrators of wound healing. Now, dermal dendrocytes are responsible for antigen uptake and processing for presentation to the immune system. They are also useful for processes involved in wound healing and tissue remodeling. The other type of dermal cell is your mast cell, which are involved in the regulation of a variety of physiological functions. So it is a multifunctional master cell with that generate and release multipotent molecules such as your histamine, proteases, prostanoids, leukotrienes, heparin, cytokines, chemokines, and growth factors. Thus, they have the capacity to be involved in regulating functions of many organs and tissues. They are known to regulate allergic responses, innate and adaptive immunity, autoimmunity, inflammation, vasodilation, angiogenesis, and bacterial and parasite elimination. Now, the mast cells are implicated in the pathophysiology of many diseases, including allergies, asthma, anaphylaxis, and gastrointestinal and cardiovascular diseases, as well as some types of malignancies. Now, the deepest layer of your skin is your hypodermis. This is also called the subcutaneous layer or the superficial fascia. This is directly below the dermis, and it serves to connect the dermis to the underlying fascia of the bones and the muscles. The hypodermis consists of well-vascularized loose areolar connective tissue and adipose tissue, which functions as a mode of fat storage, and it also provides insulation and cushioning for the integument. Let's begin with skin.
Okay, we have just discussed anatomy and histology. We will take a 5-minute break and we will continue with the rest of the lecture after 5 minutes time. Are you guys ready?
Yes, Doc.
Yes, Doc.
Let's begin with skin pathology. Under this topic, we have four main topics: inflammatory conditions, injuries, infections, and tumors. Let's begin discussing inflammatory conditions. Hidradenitis suppurativa is a progressive disease characterized by chronic and recurrent, extremely painful lesions occurring in the armpit, the groin, anal, and breast regions. It occurs due to obstruction of your apocrine glands in the hair follicles and subsequent secondary infection and inflammation. It's common among females around the age of 30 and those who are frequent smokers and obese. Flare-ups are triggered by hormonal changes, menstruation, stress, weight gain, heat, and perspiration. Although it is extremely painful, it is rarely life-threatening. Treatment depends on the clinical stage. Your mild cases can usually be managed with home remedies such as warm compress, good hygiene, wearing of loose-fitting clothing, losing weight, and stopping smoking. Moderate and severe cases may require medications such as antibiotics, clindamycin, or oral steroids and tumor necrosis alpha inhibitors. Other treatment modalities that may be of benefit include carbon dioxide laser therapy, laser hair removal, radiation, and surgery. Now, to remove lesions such as this, you need wide margins, especially in extensive cases. Limited surgical intervention can usually just recur afterwards. The first and only FDA-approved therapy for adults with hidradenitis suppurativa is a biologic agent called adalimumab, Humira, which is an anti-tumor necrosis factor drug. Pyoderma gangrenosum is characterized by the development of initially sterile, rapidly enlarging, severe painful, erythematous necrotic ulcers with purple edematous borders forming cribriform scars. They are most commonly affecting the legs, but lesions can occur anywhere. This disease is usually has an underlying inflammatory disorder such as IBD or rheumatoid arthritis. Diagnosis of this condition is based on history and clinical findings. After the exclusion of infectious etiologies, you must not biopsy this lesion. These are the different types of pyoderma gangrenosum. Treatment generally involves treating the underlying disorders such as your Crohn's with infliximab or etanercept. These are tumor necrosis factor alpha inhibitors and antagonists. In peristomal pyoderma gangrenosum, topical calcineurin inhibitors may be helpful. Surgical therapy without proper systemic treatment usually results in recurrent disease. Sharp debridement of these lesions are strongly contraindicated. Epidermal necrolysis is characterized by cutaneous destruction at the dermal-epidermal junction as evidenced by a skin sponge biopsy. The clinical presentation usually occurs within 8 weeks of initiation of a new drug treatment and is characterized by a macular rash starting at the face and trunk and rapidly progressing to the extremities. This is a type 4 hypersensitivity reaction. There is mucous membrane involvement in about 90% of cases and can involve the oral, genital, ocular, respiratory, and GI mucosa. This can also be associated with high fever and pain. A positive Nicolsi sign is often present wherein a lateral pressure on the side of the skin lesion will cause separation of your epidermis and the dermis. Stevens-Johnson syndrome and toxic epidermal necrolysis are two disorders of the same clinical entity, but your SJS involves only less than 10% of the body, whereas your TEN involves more than 30%. You should always rule out Staphylococcus scalded skin syndrome or erythema multiforme major. The prognosis is generally related to the surface area affected, with complications secondary to cutaneous damage such as loss of hemodynamic stability from insensible water losses and third spacing. So your management includes discontinuation of your offending agent and supportive therapy such as maintenance of your euvolemia, early enteral feeding, reducing infection by surgical debridement, giving antibiotics, and using non-adherent dressings. Modern burn and ICU care has greatly decreased mortality from this disease. You should always also remember to include corneal inspection by a Woods lab to evaluate for corneal sloughing. The cutaneous manifestations of epidermal necrolysis usually progress for about 7 to 10 days, while reepithelialization usually occurs over 3 weeks. Now we move on to injuries of the skin. Radiation injuries can result from exposure to electromagnetic radiation from industrial and occupational sources, or more commonly from the environment, such as your UV rays, and from medical treatments like radiation therapy.
Environmental sources of radiation damage are typically from UV radiation. The first type is the UVA. This accounts for 95% of the radiation that reaches the Earth's surface. It is the longest wavelength and it reaches into the deeper layers of the skin, with about 20 to 30% reaching the deep dermis. With the longest wavelength among the three, it has the least energy, thus, it has the least harmful type of reaction. Prolonged exposure shrinks the collagen and elastin in the skin, causing sagging. Increased oxidative stress causes photooxidation of melanin, and long-term exposure causes dark patches. This results in premature aging and wrinkling. Of the ingredients in sunblock, only avobenzone, zinc oxide, and titanium dioxide blocks UV rays of the 8 types successfully. The second type of UV ray is your UVB, which is a shorter wavelength. It has its largest effect on the surface of the skin, where it is mostly absorbed in the epidermis. UVB stimulates the production of melanin, resulting in freckles and suntan. It also causes redness, burning, and skin cancer, particularly melanoma. Aside from this, it can cause damage to the eyes and significantly increases the risk of cataracts, pterygium, and macular degeneration. UVB waves induce new melanization and increases the total amount of melanin in the epidermal tissues and results in this effect with about 72 hours after exposure. The increase in melanin serves as a protective mechanism to defend the nuclei of the basal keratinocytes from further radiation-induced damage by absorbing the high-energy radiation in future exposures. Long-term effects of exposure to UVB radiation can lead to chronic skin changes such as irregular and post-inflammatory pigmentation, melasma, and sunspots. The common ingredients in sunscreens can block UVB rays. The third type of radiation is UVC. This has the shortest wavelength, and among the three, this has the most harmful type of radiation. But the good thing is, it is almost completely filtered out by the Earth's atmosphere. Basically, to avoid environmental radiation injury, we must prevent injury by applying sunblock and sunscreen. The various forms of radiation therapy work by destroying rapidly dividing cells via damage to the nucleic acid structures. This is typically used to treat oncologic disease, but can also treat benign diseases like eczema, psoriasis, and keloid scarring at relatively low exposures. While the goal is accomplished, surrounding tissues are also affected and damaged. The most radiosensitive components of the cutaneous tissue are the basal keratinocytes, the hair follicle stem cells, and melanocytes. Damage to these cells hinders the replicative capacity of the epidermis and dermis. Acute skin changes to these structures manifest within weeks as erythema, edema, alopecia. Permanent hyperpigmentation, tightening, thickening, and fibrosis of the skin become apparent as the tissue attempts to heal. In severe radiation injury, there can be complete loss of the epidermis, resulting in partial thickness wounds and fibrinous exudates. Reepithelialization typically occurs 14 days following initial injury, provided other variables affecting wound healing are optimized. Long-term effects include compromise of the functional integrity of the skin secondary to thrombosis and necrosis of the capillaries, hypovascularity, telangiectasia, ulceration, fibrosis, poor wound healing, and infection. These can present weeks to years after exposure. The Radiation Therapy Oncology Group has provided a grading system for injuries related to radiation therapy. Treatment of minor radiation injury includes skin moisturizers and local wound care when appropriate. Severe radiation injury may warrant surgical excision and reconstruction with free tissue transfer from a part of the body unaffected by the radiation. These are examples of injuries caused by mechanical trauma. Treatment of wounds depend on the size of the defect left behind by the insult and any exposed structures that remain in the wound bed, and also the presence of contaminating debris or infection. Clean, simple lacerations can be irrigated, debrided, and closed primarily. There is no systematic evidence to guide the optimal timing of closure within 24 hours, but many surgeons will close primarily within 6 to 8 hours of injury. Grossly contaminated or infected wounds should be allowed to heal by secondary intention or delayed primary closure. In wounds allowed to heal secondarily, negative pressure wound therapy can increase the rate of granulation tissue formation. Bites from dogs, humans, and other animals can quickly lead to severe, deep-seated infections if not properly recognized and treated. The most common location of bite wounds is in the hand. Bite bacteriology is influenced by the normal mouth flora as well as the content of the offending animal's diet. Tearing dog bites cause considerably more physical trauma, but puncture-like cat bites are more likely to become infected. Typically, in wounds in areas of aesthetic importance, the wounds can be thoroughly irrigated and debrided and primarily closed with a short course of antibiotics with close follow-up to monitor for signs of infection. In areas that are less cosmetically sensitive and bites that look grossly contaminated or infected, the wounds are allowed to close secondarily. Thermal injury involves damage or destruction of soft tissues due to extremes of temperature, and the extent of injury is dependent on the degree of temperature to which the tissue is exposed and the duration of exposure. Burn wounds evolve over 48 to 72 hours after injury, and the management of thermal wounds is initially guided by the concept of three distinct zones. These are called the Jackson's three zones of hyperthermic tissue injury. Then you have your zone of coagulation, the innermost area, where you have the most severely burned area. Then you have your zone of stasis,
which is the second layer with questionable viability, and the zone of hyperemia, wherein there is only inflammation and increased blood flow. This is the outermost area and usually heals with minimal to no sparing. Treatment would involve fluid resuscitation based on your Portland formula, application of topical antimicrobials and analgesics, escharotomy and debridement as needed, and of course your tetanus prophylaxis. As for hypothermic thermal injuries, mechanism of injury is a little bit different. Direct cellular damage can occur as a result of crystallization of ice within the skin. There are also indirect effects, including microvascular thrombosis and tissue ischemia. During rewarming, further damage occurs due to fluid shifting in response to melting ice, in addition to your edema and inflammation. So these are the stages of frostbite. The first stage is just your frost nip, where the patient feels pins and needles and the skin turns white and soft. The second stage is superficial frostbite, wherein the skin is numb and waxy and frozen and may show blistering. The third is a deep stage where there is freezing of your tissues and can lead to serious infection and permanent anatomic and functional loss with possible auto amputation. Treatment will include removal of wet clothing, rapid rewarming with hydrotherapy, antibiotics, analgesics, antithromboxanes, and antiprostaglandins. The modern type of hypothermic thermal injury is the trench foot.
Now we move on to caustic or chemical injury. The extent of tissue destruction from a chemical burn is dependent on the type of chemical agent, concentration, volume, and time of exposure, among other variables. So, examples of alkalis that can cause burns are your sodium hydroxide drain decloggers, your calcium hydroxide cement, sodium hypochlorite bleach, and lye water. Examples of acids that can cause burn injuries. The most common are your hydrochloric acid toilet bowl cleaners, paint thinners, sulfuric acid, and button batteries. Now, question. Which among these two types of chemicals causes the more severe type of burn injury? Acids cause coagulative necrosis and results in the formation of superficial scar formation, which can limit further penetration and tissue injury. Aside from this, there is thermal injury due to exothermic reactions, but despite this, injuries from acidic solutions are typically not as severe as those from basic solutions. So the answer is alkali. Alkalinic solutions cause necrosis of the liquefactive type, which dissolves involved tissues, which then leaves no barriers that can prevent from further deeper tissue injury. Treatment for chemical burns include, first and foremost, dilution of the offending agent, typically by applying distilled water or saline for at least 30 minutes for your acidic burns and at least 2 hours for alkalinic injuries. Then, it is treated as per burn protocol like other burn injuries once the depth of injury is assessed. Extravasation injury is a type of chemical burn that occurs commonly among cancer patients. Extravasation injuries can cause significant morbidity among those with thin skin, fragile veins, and poor tissue perfusion. Initial presentation usually involves swelling, pain, erythema, and blistering, and early detection and prompt appropriate action is required to prevent necrosis and functional loss of the tissue or the limb involved. It may take days or longer for the extent of tissue damage to demarcate.
After the wound demarcates, full-thickness skin death should be surgically debrided and managed like other wounds based on depth of injury. It is best to avoid cold or warm compression because the impaired temperature regulation of the damaged tissue may lead to further thermal injury.
Now, pressure injury occurs in four stages. The first is just erythema with intact skin. The second is partial thickness injury with blistering or exposure of the dermis. Stage 3 is where you have full thickness injury. And stage 4 is when your full thickness injury involves destruction of underlying muscle, bone, or tendons. Tissue injury from pressure necrosis occurs most commonly over bony prominences due to the inability of redistribution of forces. So it most commonly affects your ischial tuberosity, greater trochanter, sacrum, and the heel. The development of pressure ulcers is increasingly regarded as a marker of quality of care. Thus, prevention is key, and avoidance of prolonged pressure to at-risk areas is important. From a wound healing perspective, patients should be nutritionally optimized, and surgical debridement is done as needed. Now we move on to infections of the skin. Impetigo, erysipelas, cellulitis, folliculitis, and simple abscesses fall in the category of uncomplicated skin infections. You can see in this figure in which layer of the skin these infections originate from. And you see that the most common etiologic agents are your Staphylococcus aureus and Streptococcus pyogenes. To treat these infections, you have to be able to recognize them early. And if you catch them early, hygiene and warm compresses are enough to treat it. But if they progress to a severe form, wound cultures, antibiotics, incision and drainage and debridement, plus supportive care and resuscitation is important to avoid the impact of sepsis. Now, your human papillomaviruses are of many different types. 80 of these types have cutaneous manifestations. The most common, HPV 1 to 4, are the causative types for your Verruca vulgaris, Verruca plantaris, and Verruca plana. Histologically, they are characterized by non-specific findings of hyperkeratosis, papillomatosis, acanthosis, and the hallmark koilocytes. Subtypes 16 and 18 are high risk with highly oncogenic potential. Subtypes 6 and 11 also have oncogenic potential but of the low risk. These types are the ones that cause your condyloma acuminata. Treatment would require removal of warts if symptomatic or it causes physical or emotional discomfort. Removal can be done by cryotherapy or topical applications or surgical removal. Now, HIV has multiple primary cutaneous manifestations, and they can also cause secondary manifestations from other infectious or neoplasmic conditions. Okay, so now we can finally move on to the last topic, which are your tumors. Okay, we're taking another 5-minute break. Are you guys still there?
Yes,
Yes, Doc.
Yes,
yes, Doc. So,
Yes.
Yes, Doc.
Doc.
All right.
Yes, Doc.
If you guys were paying attention, can you tell me what that person, that guy with the modern trench foot was doing why he was able to get hypothermic injury of his left foot, and most probably on the right also. So kindly type it down in the chat box. So uh, that the picture was shown in the hypothermic injury of a modern trench foot. If you remember, the guy removed his cleats uh, and showed us the condition of his feet. So, what type of activity did that person most likely do that made him predisposed to have that type of injury? Kindly type it in the chat box. Thank you. Okay, did any of you get my question? The question was, what is the most likely activity that example of hypothermic thermal injury was doing? The picture showed a person. Yes, there was a frostbite, but what type of activity was that person doing? So he was wearing cleats, and cleats are usually used for they're used to lock the feet of the person wearing them. Any other ideas?
Yes, Doc.
Yes, Doc.
Yes, Doc.
Okay, here we go.
Okay, so now we can finally move on to the last topic, which are your tumors. Now, for benign tumors, this will encompass your common moles, your cystic lesions, your actinic keratosis, and some other lesions. Now, the most important of these is your actinic keratosis, which are neoplasms of your epidermal keratinocytes, and they come from sun damage. And this is the precursor cell for your squamous cell carcinoma. Now, as for the malignant tumors, these are the three most common types. Your basal cell carcinoma is the most common of all. Your squamous cell carcinoma is more common in the immunosuppressed patient population, and your malignant melanoma is the most common life-threatening skin cancer.
Basal cell carcinoma is the most common skin cancer that arises from the epidermal stratum basale on sun-exposed areas. Cumulative sun exposure is the main risk factor for its development. They usually present as slow-growing, waxy, or shiny papules or nodules with pearly rolled borders, umbilicated centers, and telangiectasia. They are slow-growing and locally destructive, but they virtually have no metastatic potential. Diagnosis is confirmed with a shave biopsy, which allows visualization of nests of basophilic cells invading into the dermis. Histologically, the peripheral palisades will tell you that this is your basal cell carcinoma. There are different types. The nodular basal cell carcinoma is the most common type. The superficial basal cell carcinoma is one of them. Morphic basal cell carcinoma is the most aggressive type. And we also have the pigmented basal cell carcinoma, which is difficult to tell if it is melanoma or not. Treatment would involve excision, but it is best to use Mohs surgery. So this slide shows us the difference between a conventional excision and Mohs micrographic surgery. In conventional surgery or excision, we usually do an elliptical excision with a margin of normal tissue around the tumor, and in the pathology laboratory, the pathologists do bread loaf slicing, and the sectioning will show them on the slides where the tumor is. Sometimes conventional excision and bread loafing will miss areas of retained tumor, whereas in comparison, your Mohs micrographic surgery happens by doing small cuts around the tumor and sending as specimen the outermost margin of the tumor. This is the deep and peripheral margins that are checked by the pathologist under frozen section. While the surgery is ongoing, when the pathologist says that the margins are positive, the surgeon can go and continue to take more margins and send again for frozen until such time that the frozen section says that there are no more cancer cells. So your Mohs micrographic surgery is a way for the surgeons to take all of the cancer cells while taking the least amount of tissue.
Now for your squamous cell carcinoma, this is the second most common skin cancer. It is locally destructive with effects that may potentially metastasize and cause death. Most commonly presents with a hyperkeratotic lesion with crusting and ulceration, and can also present with pink plaques with scales or erosions. So they usually spread to the lymph nodes. Now, risk factors: sun exposure is the most common causative factor, but exposure to chemical carcinogens such as prior radiation, sites of burns, or chronic trauma, or chronic immunosuppression also predispose to squamous cell carcinoma. Of note, a history of actinic keratosis, which is the precursor, is very important. Squamous cell carcinoma commonly occurs in the lower lip, as compared to your basal cell, which occurs in the upper lip and higher. To diagnose this, you have to do a skin biopsy, and the pathology will show a typical nest of squamous cells arising from the epidermis and extending to the dermis. The malignant cells are often large,
with abundant eosinophilic cytoplasm and large vesicular nucleus, and there are keratin pearls that are present. So again, actinic keratosis is your precursor. Bowen's disease is the squamous carcinoma in situ. Erythroplasia of Keyrat is a penile squamous carcinoma in situ. And a squamous cell carcinoma that arises from a burn scar is called a Marjolin's ulcer. Treatment for your squamous cell carcinoma requires excision and sometimes Mohs surgery. They may also require lymph node biopsy and radiation or chemotherapy. So your malignant melanoma, as previously stated, is the most common life-threatening dermatologic disease. It is commonly manifested as a cutaneous disease, and these are the things that you must look out for. Because malignant melanoma usually arises from a pre-existing nevi, then you have to keep checking your moles. Now, what do you look out for? These are the things: A, B, C, D, and E. Asymmetry is wherein two halves of your mole does not match. Border is when you have irregular borders. Color is when there are different colors or shades. Diameter is when it is more than 6 millimeters or more than the diameter of your pencil eraser. And you have to watch out for evolution or changes with the lesion. If you don't have any of those, then you don't suspect melanoma. Of course, there are other features like elevation, new growths, and chronicity. Now, there are different types of malignant melanoma. The most common subtype is your superficial spreading. This accounts for 50 to 70% and arises from, again, the precursor melanocytic nevus. The nodular subtype accounts for 15 to 30% and typically arises de novo. So it doesn't come from an old mole. It is most commonly in men and on the trunk. This is aggressive with an early vertical growth phase pattern and is often diagnosed in the later stage. Thus, this type is the most aggressive type. Then you have your lentigo maligna, which represents 10% of malignant cases. It is the least aggressive subtype, and typically arises in sun-exposed areas of the head and neck. Thus, it has the most or the best prognosis. And the acral lentiginous melanoma accounts for about 30 to 70%. This subtype is not thought to be due to sun exposure, so it's usually found with the Hodgkinson sign. Now, your malignant melanoma is graded according to the Clark's or the Breslow's grading. The Breslow tumor thickness has now replaced the Clark's level as the most important prognostic indicator for melanoma staging. The Breslow tumor thickness measures the depth of penetration of the lesions from the top of the granular layer of the epidermis into the dermal layer, and it is directly related to the risk of disease progression. Stage 4 malignant melanoma is known to have metastasized to different areas such as your brain, your bowel, your heart, and your liver and your lung. Treatment for malignant melanoma includes excision with margins with a sentinel lymph node biopsy for staging. You must also include chemotherapy, add biologic therapy such as your interferon alpha, and radiation therapy. Patients with early melanoma are at low risk for recurrence but are at high risk for the development of subsequent melanomas. Those with more advanced melanomas may recur and metastasize at a higher rate. So, patients
surveillance is essential. And finally, this is my last slide. Thank you for listening and see you after lunch. Bye.
Okay.